Today we are doing the first of two anal sac adenocarcinomas. So this is a little mixed breed spaniel dog that has an incidental finding of an anal sac adenocarcinoma previously identified on rectal exam. It has no evidence of lymph node enlargement. It's not straining to defecate or anything like that, so we're going to go in surgically and remove it. If you haven't already done so, please subscribe to our channel. Make sure you turn on notifications so you'll get a ding on your phone the next time we live stream. So the dog is in lateral recumbency, left side down, and I'm incising right over the anal sphincter, and putting in some retractors, and the mass I can feel underneath the skin, so it should be pretty straightforward to remove. So that's the anal sphincter right there, and the mass is going to be just right underneath it. So get a towel clamp, please, just to raise this up here. And then do we have our, get a debakey and our hook. Are we waking up a little bit? So that's the anal sphincter right there. And I don't put anything in the gland with my anal sac adenocarcinomas to identify it because I can see it really clearly just from the fact that there's a mass there. If I'm doing anal sacculectomy for like recurrent anal sacculitis, then I put a Foley catheter in the gland in order to identify it. But again, if I'm doing for an anal sac tumor, then that's not necessary. Are we okay to go ahead? Okay. So I'm just taking the fat off. And I love this little hook cautery tip that I made. Really nice for delicate dissection. And again, I can palpate that mass just right down here underneath the anal sphincter. It's right up in there. So I'm incising the anal sphincter here. That's the anal gland right there. Can you suction in there, please, for me? Suction down there. Can I get a smaller Gelpy, please? Like a 1?
A 1?
Yes, please. Yep, that's right. I'll get back to them. Yep. I'll probably just keep working here, and then if I have, or at the end, I'll go back and answer questions. Thank you. So I'm just splitting that anal sphincter here a little bit more. Might need you to hold on to that for me, please. Going back and palpating so I can feel the mass. This is one that actually may have been helpful to put something in the anal sac. And I'm not concerned if I inadvertently go into the rectum because I can just close that primarily. I'd have you come around the other side, please. And let's get a some kind of instrument here on the anal gland. So this is the anal gland here. And then the tumor is, let's pull that way, please. So that's tumor right there. So I'm down to rectum. I really like this hook cautery tip that I made because I can be very specific about what I'm cutting. So I introduce the hook and then I start the cautery. And the only thing that gets cauterized is what's in the hook. So I think that that's the duct right there. So that's the anal gland duct right there. So that's the duct right there. So I'll just transect that. I'm not worried about ligating it. And that's right up against the rectal wall there. I think we might be getting a little light again.
Yeah.
And these guys were always kind of battling blood pressure versus depth of anesthesia, and so sometimes they can wake up a little bit. Okay, so that's the mass out there along with the anal sac. And then that's the sphincter that we've transected. This is a really easy one. I've got one the size of a tennis ball that I'm also doing later on today, so that'll be more challenging. All right, so I can take out that. We can see more clearly the two, so that's anal sphincter there and anal sphincter there on either side. So we'll just flush that out, and then I'll just use maybe some 3/0 PDS there, and then some sub-Q, and then intradermal. If you guys are happy to take that over for me.
Do you usually have them on lateral recumbency?
I always have them on lateral, yeah.
I thought I'd duck in because I feel like I don't see many where the mass is somewhat discrete and
Yeah.
relatively small.
Yeah. So this really clearly demonstrates where the anal sphincter was and the defect that we had to create to get in there. Just make sure that there isn't a little bleeder on the rectal wall. Can we get the regular cautery tip? Thank you. Yeah. All right, so that's rectum in there.
Yep.
And then that's anal sphincter there. So this should come together really nicely. All right, so I will leave Yui to close that up, and I'll come back and have a look at the questions, make sure there isn't anything that we missed.
Fragments in skin, Charles.
Intradermal, yeah. So let's just see here if I can improve the lighting a little bit, maybe. Not much. All right, so you can see what Ewan's going to do there as far as closing that anal sphincter is concerned. We'll leave it on. You're happy to keep it running, Huey?
Yeah, of course.
And I'll just see if there are any questions that I have missed. All right, so hello from the Philippines, Miami. We already answered that. So we're not removing sublumbar lymph nodes. They were not enlarged in this dog. We're just going to monitor. So the electrocautery that we have, this one is called a... Can you read that?
Which
The
one?
top, yep.
Meditol.
Metatome from Mediquip. But any human electrocautery unit is fine. Costa Rica. Surgical margin, so it is technically just a marginal excision, so we're not doing a huge wide margin. We're just trying to get, as best as we can, get microscopically complete margins, but we aren't going for 2 centimeters like we do with most other tumors. And what we find is that in dogs, local recurrence is rare. In cats, however, local recurrence is the major issue that we have with anal sac adenocarcinomas. So there's 0 chance of fecal incontinence in this dog. I've never had it happen before, so it's not something we're concerned about at all. And that's pretty much it. Now I'm going to pass the microphone over to Yui, and he can just keep you informed of what's going on there.
Hi guys, just closing up here. Just closing anal sphincter, just judiciously in a couple of cruciates rather than running a simple continuous through it. Purely from a risk kind of mitigation point of view. If you have one suture let go, you're still going to have a functional sphincter rather than if you have one suture let go that's part of your continuous closure, potentially you can get dehiscence of that. In terms of closure on these guys, you don't necessarily need to get super carried away about trying to tack down all your dead space. In fact, trying to avoid that often helps you get a bit more of a cosmetic closure, and seroma's often not a big issue in these guys, even with the bigger masses that we take out.
There's a question about whether the size of the tumor is prognostic. This one is very small, and so I do believe that the smaller tumors have a better prognosis. I think kind of the guideline is bigger or smaller than about 3 or 4 centimeters.
Yeah, 3 to 4 centimeters. That was the Julius paper, I think.
Yeah, and so bigger than 4 centimeters has a worse prognosis than smaller. Lymph node metastasis at the time of diagnosis is not ideal, but what we find is that they'll park in the lymph node for years often, and you know, it's not that common that we see them going beyond the lymph node into the lungs and liver and things like that. So we can treat the local lymph node metastasis with just another surgery and still, even without chemotherapy, get fairly prolonged survival. And then if you add palladia on top of that, the survival can be even better.
Pull a gulp out there. So, as always, with these, we just want to make sure that we don't have any residual bleeding. These Gelpies are really, really good retractors, but as you can see, once you take them out, some of that retraction can put pressure on blood vessels and prevent any ooze. So that's a perfect example here. We've got a bleeder in the sub-Q that was being controlled by those Gelpies. The last thing we want to do is just carry on merrily and leave that alone, because it's going to contribute to dehiscence post-operatively if we have a hematoma form there. You can see there is a reasonable amount of dead space in this incision. It would be really easy to get quite carried away tacking down all this sub-Q, but it's not necessary and can be detrimental in some cases. Pretty much anywhere else on the body I would be a little bit more aggressive with how much dead space I close, but this is kind of a normal cavity here that tends not to have a major issue. And post-operatively for these guys, breakdown is an uncommon complication, but a complication that does occur. Even in very severe cases of breakdown, it's usually not an indication for repeat surgery. You can have animals, if we've had to do any resection of the rectal wall, if that breaks down, you can end up essentially with frank fecal contamination of the wound. And as long as the wound is able to drain adequately, just judicious wound management with flushing and lavage is usually adequate to control these without the requirement for repeat surgery. You know, if you have those dogs that break down, you know, the next surgical step would be something like a rectal pull-through, which I think is hyper-aggressive and unnecessary in the vast majority of cases. Unless you can't attain good wound management in those cases. If you just have local breakdown with no fecal contamination or anything like that, I would almost universally recommend managing those conservatively and just daily lavage, even with tap water at home if the owners are comfortable with that, and just touching base with them every so often, making sure that the wound still looks good. Is that your experience as well, Anna?
Mm-hmm. Definitely.
I have had one of these come back 48 hours post with a substantial amount of bleeding that I think was probably a little bleeder from a branch of the caudal gluteal. That, of course, wouldn't stop out of theatre, wouldn't stop with digital pressure and gel foam in the wound and all that kind of thing. It had broken down. But of course, by the time I got it into a theatre and rushed it in and got in there with a ligashore, it had stopped. Fairly uncommon complication. Fistulation of the duct is reported, so ending up with kind of chronic fistulation from the duct of the anal sac is reported. I know Julius Liptak in Canada does a modified approach to these and actually goes via the duct in the kind of perisphinctal area and excises the whole duct to the level of the kind of mucocutaneous junction. But we tend not to see that complication. I know even in this case, Charles doesn't tend to fret about that too much or even ligate the duct in some cases. Seems to get away with it. Beautiful. You happy to run some intradermals over that, Anna?
Yeah.
We'll get some 4O monosin, please. And I'm going to stop the live stream and take the pressure off you, Anna. One sec. Just check if there's any questions. It doesn't look like there's any more questions. Thanks for listening in, guys. And I think Charles will probably live stream another one.